Welcome to the AA Podcast, our little corner of the web where we are not afraid to discuss tough questions like,
when did nutrition, health, movement, and stress management become alternative medicine?
Where we embrace challenges in all aspects of life to become healthier and stronger versions of ourselves.
And where food and movement are the best kinds of medicine, and cooking meals at home is a revolutionary act. Hello, and welcome back to another episode of the AA Podcast. This is Ashley Olson.
And I'm Andrea Crane.
If you are tuning in this week, I hope that you had a chance to listen to last week's episode where we began our discussion on PCOS, laying the foundation framework of what it all is. And today we're going to get into the nitty-gritty of what we can do to help those
Really,
suffering.
all I think we did was muddy the waters, but
So you might want to listen to the episode a couple times and see
that's
if you
right.
understood everything. But before we get into all of this, let's do our weekly Bible verse, and mine is coming from John 16:33. It says, "I have said these things to you, that in me you may have peace. In the world you will have tribulation, but take heart, I have overcome the world."
All right, mine's coming from Psalm 119:30. I have chosen the way of faithfulness. I have set my heart on your laws.
Love it.
All right.
All right, Andrea. So we are going to start with some things that you should be having your doctor check or asking, or your doctor should be checking normally if you
Mhm.
have all the symptoms that we described in our last episode.
Yeah, and so I'll just go over a few of the most common symptoms that I see in patients that make me start thinking about an evaluation for PCOS. So it could be, and I'll just start with the big one, and that is infertility issues. So if someone is trying to get pregnant and it's just taking a long time, and they seem to be young and healthy and kind of should be in the prime of their fertile years, then I might start thinking about PCOS. If they have a history of poorly managed periods of heavy bleeding, heavy cramping, we talked about, having less than 8 periods a year, having a cycle that is over 35 days or just terribly irregular, then that starts me thinking about PCOS. Also, gosh, those things coupled with problems with glucose metabolism. So this could be, increased central adiposity, or that belly fat, or difficulty losing weight, and stress response, and that is all so nebulous. But when you put the picture together, it's putting all the pieces together that can kind of start you down the road of thinking about PCOS. And, I like to ask my patients really, really specific questions about their menstrual history. Like, even if I'm talking to a woman in her 40s, I want to know, when did you first start menstruating? How old were you? What's the menstrual history like in your family? Do you remember, having periods that settled down and became normal and predictable within a couple of years? And sometimes, Ashley, they'll say, "Oh yeah, it was completely normal and completely predictable within a couple of years of cycling." So, like, by the time I was 16, and then I ask a few more questions, and come to find out she's been on birth control for the last 25 years because she had horrible periods starting off, and someone put her on birth control, and then she's just been on it, and that has regulated her cycle for the last 20 years. So yeah, it becomes all things become clear the more questions you ask.
And when
So
you say regulated, I think you
mhm.
mean kind of more an air quote regulated, because it's not really
It's
truly
an
regulating.
artificial, right?
Yeah.
It's an artificial regulation, using synthetic versions of hormones. So you're essentially, and I prescribe hormones all the time. I typically prescribe bioidentical hormones. That's my preference, for, perimenopausal and menopausal women. But I don't often prescribe synthetic hormones for younger women to regulate periods. Now, I will say, I never say never. There are some circumstances where that's the tool that we have to use in the short term. But that's certainly not my preference.
Okay. So what should your doctor be looking at? And
Yeah.
where would you start with somebody?
So, as I mentioned before, really, really good menstrual history, just so you kind of know where things began, because these things don't happen in a vacuum. There are clues, breadcrumbs, if you will, throughout the course of their menstruating life, and you just have to ask enough questions to be able to pick it up. Now, also, there is a huge place for labs. All right. So even though this is one of my mantras, I treat the patient, not the lab, right? I treat the patient that's sitting in front of me, not the lab value. Um, However, getting labs and figuring out what these hormone levels are, figuring out what their blood sugar levels are, figuring out if they are estrogen dominant, that becomes really important when it comes to evaluating PCOS. And that can tell you a lot. But I never order labs without taking a history. That is really, really poor medicine. So you only want to order labs in order to confirm what you're already thinking, right? You don't just order a million labs hoping that something will come back, right? So you order the labs based on what you're already thinking. And so, but I also want to say it's extremely important, and I mentioned this in the last episode too, extremely important to rule out, we would call it alternate etiology. So again, we talk about those symptoms where a woman is having this set of symptoms, and boy, it sure sounds PCOS-ish. But you know what? I also need to rule out things like, well, does she have a tumor? Does she have adrenal hyperplasia? Does she have Cushing's disease? Does she have a prolactinoma or a tumor that is creating some of these signaling hormones? So that is one of the reasons that it's so important that you have a knowledgeable provider to take over this exploration, because it is incredibly complex, and it's more than just diagnosing the PCOS. It's actually ruling out some of the scary things that can be causing these symptoms. I mentioned ovarian cancer, and I mentioned uterine cancer, and I don't like to scare people with the big C word, but the fact is there's an awful lot of cancer out there. And when you're having these weird nebulous menstrual symptoms, they need to be evaluated, and the scary things need to be ruled out.
Mhm.
So I can't stress that enough, that you need to have a knowledgeable provider who is ordering the proper tests and looking at things in order to make sure that you don't have something more immediately serious going on.
Mm.
Um, and then the next thing is, discussing weight loss efforts, right? Like, if a woman is beating her head against a wall and she's been eating in a hypocaloric state for, I mean, Ashley, this happens to you all the time. You've got women existing on 1,100 calories a day, and they're, and now sometimes people are eating more than they're reporting, right? And yeah, you've you've had lots of great posts about this, about bites and licks and tastes, and they all add up calorically. But there are lots of women who are really, really sincere in their efforts, and they are literally monitoring everything that goes in their mouths. They've been eating 1,100 calories for the last 3 years, and they haven't lost a pound. And so, yeah, you need to discuss weight loss efforts, see where she's at, and see what she's done, and how is she trying to manage this. Also, so this is something that doesn't come up enough in my estimation. But if someone has PCOS, up to 50% of women who have PCOS can also have sleep apnea.
Mm.
This is a problem. This is a
Yeah.
big problem, because have we done an episode on apnea?
Well, we've done an episode on sleep.
Oh, good. Okay. Okay. Hopefully we got into apnea. I can't
We
remember
did.
anything.
Yeah, and
Yeah. Okay. Good.
we highly stress that if you have any type of sleep
Mhm.
um,
Irregularities.
thank you.
Mhm.
To
And then
definitely
we
get
get
that
checked
checked
out.
and not to
Yeah.
let that just slide by and say you'll sleep when you're dead, because you will be dead
For
sooner than
yeah, for
you'd
sure.
like.
Because literally, your body thinks you're dying every night of your life, and it
Mm,
is making changes to your physiology to
yeah.
try and survive that are detrimental to your long-term
Mm.
health. So
And
do
we
get
also
that
talked
checked
about making sure that you're not just sleeping through with your mouth open,
out. Mhm.
mouth
Yeah,
breathing, making sure it's
absolutely.
nasal, mostly
Yeah,
nasal breathing. So,
absolutely.
those are definitely things. If you haven't listened to that episode, definitely check out the sleep episode.
Oh, yeah, go back and listen, and there's
It
probably,
was
I
so
don't know,
good.
600 of those. So, yeah. So let's
But
see, I
this makes sense
also
because sleep
yeah,
has a huge play on stress.
yep,
And so we've
right.
already been talking about how do you control your stress. And one of
Mhm.
the biggest ways you can do that is improving your sleep quality.
Without a doubt. Yes, and that is going to be part of any treatment strategy is to
Mhm.
optimize sleep for
So you
PCOS.
might say, "Yeah, I sleep great." But do you?
Exactly. Yeah. Yeah, and there are and again, this is where a knowledgeable provider is so important because there are very, very specific questions that we ask to determine like how good is your sleep quality. So they're very specific questions. So then I would also I look for things like infertility, miscarriage, family planning efforts. If you've got a woman sitting in front of you and again she's coming off as very PCOSy, uh I want to know, do you have family planning issues? Like are you 38? Are you 40? Are you 35? Like how old are you, and how many children do you want to have, if any? If you want to have kids, then there is some immediacy to getting this figured out, right? But if someone tells me no, children aren't really in our future, then I know that okay, so we've got some time to really kind of get this under control, slowly and steadily. So
Mm.
you got to understand your patient, and you got to understand their timeline and what they're dealing with. Also, you need to be evaluating for non-alcoholic fatty liver disease or NAFLD. This is a very, very common condition now. You want to be checking for an enlarged liver. You want to be checking for liver enzymes that are elevated. So, along with that lab profile, you look at liver enzymes, you look at liver function. You also want to look at cholesterol profile because that can clue you into PCOS too. If there is an increase in triglycerides, if there is an increased total cholesterol and also LDL cholesterol in an otherwise healthy woman, then I am starting to think PCOS in those cases.
Okay. So, with PCOS and pretty much with every syndrome or disease, there is a psychological and emotional
Mm,
component that definitely
yeah.
hits us. So how are you helping your patients navigate their emotional and psychological state when treating and going through
Mm,
something like PCOS?
that's a really good question because this is so it's so emotionally taxing, right?
Hmm.
Like there's the physiology, right? We can look at just from the neck down. There's just the physiology of it, and that is frustrating. But then there's also the emotional toll that it takes. And so for some people, if for instance, if they are dealing with infertility, this is some of the most painful, uh, whew, uh, some of the most painful problems that, couples can have are issues with fertility. Um, because there is a clock ticking, right? You don't want to have a brand new baby when you're 50 years old. And the chance of that even happening is almost nil. And so there is a window, right? And so there's a lot of pain points there that you really should be exploring with patients. Also, some of the symptoms of PCOS are really frustrating and can be embarrassing and potentially debilitating socially for people. Things like cystic acne, things like hirsutism, or, male patterning of hair growth in places where you don't want it. Like, we joke about the mustache, right? But for a lot of women, it's not anything to joke about. It's things that they really struggle with. Um, Things like weight gain and inability to lose weight, that really takes a toll, especially when she's working as hard as she can, and her body, it's just like this ultimate betrayal, right? Like the conveyance the conveyance matter that you are that is dragging your brain and your spirit around, this body that we have that is supposed to serve us until, until we're 80, 90 years old. That it's like it's betraying you.
Mhm.
And nothing you do really makes a difference or seems to make a difference. And so, yeah, it's really important. In fact, I saw some pretty staggering statistics on how many women with PCOS are being also treated for anxiety and depression, and it's quite high. It's up to, I think the last numbers that I saw were, 30 to 40%.
Mhm.
And so that's significant. So you need to check in. Patients check in with your providers. Providers check in with your patients and see how they're doing, and making sure that, if there is a need for counseling, if there is a need to treat depression, make sure that that you're asking the questions of your patients. Are you having thoughts of self-harm? Are you having thoughts of hurting yourself or taking your own life? You've got to bluntly ask the questions. And your give a crap has to be absolutely high as a provider.
Mhm.
It really does, because patients can tell if you don't care.
Yeah.
um
If it was just a routine
yeah,
question.
for sure, for sure.
Yeah.
Yeah.
So let's kind of get into maybe some diet things
Mhm.
that individuals can do.
Yeah.
So prior to us getting online, I had asked about the ketogenic diet.
Mhm.
I had heard that it could be helpful, and I'm sure I'm not the only one that has heard that. So, what
Mhm.
are your thoughts on that? And yeah, let's start there.
Okay, yeah. So keto. So my my default position when I hear keto and women is right. Like I kind of run out of words at that moment, and here's the reason why. One, because it's very difficult to find two people who can totally agree on what a ketogenic diet really is. Um,
And we did do, I'm pretty sure we did a keto
I'm
episode.
pretty sure surely we did.
Yeah.
Yeah. And so if you listen to that, you no doubt heard that I am not a big fan of a ketogenic diet long term for women. Now, that said, there is a place for short term um getting the sugar and carbohydrates out, just to break habits. It's
Mhm.
incredibly important to break dietary patterns, because and this has been said before ad nauseum, d but dietary changes are such that it's not like smoking, right? It's not like
Mhm.
drug use or alcohol use where you can just stop. You cannot just stop eating. You have to fuel your body, you have to eat, you have to make those choices. I would submit that it is probably easier to just stop something than it is to moderate something that you have to do multiple times a day. And so
Mhm.
that's it's incredibly hard. We use food for all manner of things, to emotionally soothe ourselves, for fuel for our bodies. We use it when we're angry, when we're sad, when we're frustrated, when we're elated and happy. Like, we use food for a lot of things. And so in order to break cycles, sometimes something like a keto diet, where you can just completely reset your taste buds, um a- a- and generally this is the most powerful when you're resetting. What does sweet taste like, right?
Mhm.
If you're at a place where a blackberry or a blueberry doesn't really taste sweet to you, then you probably need a reset.
Mm.
And getting the sugar out, eating a little higher protein, higher fat, lower carbohydrate might be good for a short prescribed period of time. So
Yeah.
yeah, it's good for resetting glucose metabolism, which we talked about earlier too.
Which in turn can help reduce some of that initial inflammation.
Yeah, absolutely.
Yeah.
Absolutely.
So you're if you've tried the ketogenic diet before, especially if somebody maybe with PCOS, you're probably like, "Oh my
Mhm.
gosh, I felt great on it." But there probably was a time either one, it wasn't sustainable, which is the big
Right.
one, but
Mhm.
two, you might have kind of hit that curve where it
Mhm.
actually you needed to transition off of it. So I want to talk about
Yeah.
that. Like if somebody wants to just kind of get a head start, quote unquote, with
Mhm.
getting keto, getting their food in check, getting some maybe that initial inflammation down with a ketogenic diet, how would
Mhm.
you advise them to start transitioning off of that,
One word,
especially with somebody with PCOS?
yeah, yeah. And this will kind of be a blanket statement for any woman wanting to transition off of keto into something really healthy long term. Fiber is the first word of the day.
Hmm.
So you can start, see, this is part of the uh, this could arguably be the biggest issue. Now, again, guys, I'm not talking about a dirty keto. I'm not talking about, bacon and lunch meat 24/7. That's not the keto I'm talking about. I'm talking about a clean keto with good sources of fats, with um, as good of protein sources as you can afford, that kind of thing. That's what I'm talking about. So no dirty keto. Please hear me. That's not what I'm talking about. That's not good for you. Um, but if you've got lots of non-inflammatory fats, if you've got lots of good, clean protein sources, then how do we slowly transition back into a sustainable way of eating that's going to be good long term, and specifically for PCOS? So fiber is the name of the game. That's where we want to start. I'm a huge fan of eating plants. We've got to support microbial diversity. So in your gut, you've got all these microbes, and it has been shown, in fact, some of the latest research on PCOS has shown that more often than not, a woman has a dysbiotic gut. This means that you have elevated populations of bacteria that are not necessarily your friends, exerting way too much influence over your body when you have PCOS. So, the standard American diet is the absolute worst thing that you can put in your mouth when it comes to PCOS. It is the worst. Okay.
Hmm.
It's full of it's full of processed carbohydrates, processed protein. It's full of horrendous inflammatory fats and oils. So when you think of whatever the opposite of that is, eat that. So lots of plant matter, and I can't stress this enough. Um, we want lots of fiber in the mix. And here's why. So one, we need fiber for microbial diversity, because all those little microbes, all those little bacteria, they eat the fiber, okay? That's their diet. And so we need to feed up populations of good beneficial bacteria. So that's number 1. Number 2, if you do not have enough fiber in your diet, think back to the etiology of PCOS. What did we talk about? Well, we talked about, one, an excess of estrogen, right? The E3, the estriol or estrone form of estrogen. We've got tons of it running around. And then 2, we've got excess testosterone. So how do you get rid of those hormones? You cannot get rid of those hormones unless you are pooping every single day of your life. You can't. You've got to get rid of those things. And fiber, keeping the beneficials fed up, is the best way to do it. So we've got to have 25 to 35 grams of dietary fiber every single day, and that is a non-negotiable. So that's the best way to start to come off of that strictly keto and to introduce more plant matter, more fiber into your diet. Go there first.
Awesome.
Yeah.
So, what would you so if you had a client that came to you and you're like, "Okay, I'm all in. What do I need to be eating? What is there a certain diet plan, diet um, name that I should be following? What would you say?
Oh gosh, if somebody really wants the name of something, I would probably point them towards like a Mediterranean. If there's something that they want to be able to look up and Google and okay, what can I
Have a
eat?
cheat sheet, grocery
Yep,
list. Yeah.
you betcha. Mediterranean. It is the most studied diet in the history of diets. And there just isn't anything wrong with it. It's just
Yeah.
it's amazing.
And
So
thankfully, it's really delicious.
yeah, it is. It's totally delicious. Now, if you want, I don't know, I guess if you want a little more latitude, I would say again, fresh fruits and vegetables, lots of well-sourced protein. I typically will give my patients dietary targets to hit as kind of a loose guideline of where to start. And so I would say try to get your protein into the low triple digits. Start there. I would say keep your fiber at 25 to 35 grams a day. Make sure that you are not eating inflammatory fats. Get those vegetable oils completely out of your diet. And then beyond that, I would say work with somebody. If you are not getting results from this very basic information, then
Hmm.
work with somebody who's knowledgeable, somebody like Ashley. There are nutritionists, there are trainers who are really, really adept in the specifics of nutrition. I've seen Ashley work with some people with just all manner of autoimmunity and PCOS and hormonal issues um, and be able to get them on track. So yeah, that's my plug for working with somebody who knows a lot. Yeah.
Yeah. Um, and what's great too is I also have a little resource in my back pocket.
Via text. Yes.
Yes, exactly. So it's really a two for one.
That's amazing. Yeah, and
So
vice versa.
I mean, obviously, food
Mhm.
is a very functional way of treating a lot of
Yeah.
these things that we have done episodes on. But
Mhm.
can you dive a little bit deeper into some of the functional ways that you
Yeah.
also help?
Yes, and so I'm gonna rattle off some supplements and some botanicals that I like to use. However, here's what I'll say. I use these in different combinations based on one, what my patient presents like, and two, what her labs look like. So in the patient, now I've talked about two types of females that present with PCOS. One is the kind of standard stereotypical difficult weight loss, increased adiposity, um, and so that particular presentation, um, I will use different combinations of botanicals than I will use for the extremely lean, uber athletic woman who has infertility and PCOS. Okay, so it all depends on your individual presentation. And then, as you can imagine, there's like a myriad of women in between those two as well.
Mhm.
So this is all highly individualized, and I cannot stress enough, please work with somebody who knows what they're doing. But I'll go through some things that I have in my toolkit. First of all is myo-inositol, or just inositol. I will typically have women use this. This is good for glucose metabolism. Um, that in conjunction with something like berberine. Berberine has been used in the bodybuilding community as a glucose disposal agent for a long time now. It's got a really amazing track record. It's kind of been called the botanical metformin. So a lot of my more naturally minded women will be like, oh, I don't want to take drugs, right? I hear a lot of that in my practice because, these are the types of patients that will seek us out. And so I will use something like a berberine and a myoinositol if I've got blood glucose dysregulation. And let's see, what others can I put together here? If I have someone with elevated estrogen, let's say that they have profoundly elevated estrogen, I will use something to enhance the excretion and metabolism of estrogen in the body. Now, you want to be really careful with this because sometimes women have very low estradiol, right? That's the good estrogen that we need. And you don't want to mess with that. So, this is why labs are so, so, so important. But if I need to get rid of estrogen, I will use a combination of like calcium D-glucarate. You can use DIM or diindolylmethane. You can also use like an indole 3 carbinol, but I primarily use DIM now, the diindolylmethane. You can also use there's a product called Brocomax, which if you eat cruciferate veggies, in particular broccoli sprouts. Broccoli sprouts are incredible for getting rid of excess estrogen. Now, if you can't eat a truckload of broccoli sprouts every day, I get it. There is a product called Brocomax that has some extract of broccoli that I really like, and I will use that in women with excess estrogen. Now, if they have evening primrose oil as well, to kind of boost progesterone and reduce estrogen. Now, if someone has excess testosterone, I will often use saw palmetto and extra fiber. And again, the combinations just really are patient dependent, but this is just sort of a high level view. So again, saw palmetto, which is used for prostate issues in men. Women don't have prostates. Hopefully you know that you do not have a prostate. But you might be wondering, why are we using saw palmetto? I don't own one of those things. It's because it inhibits testosterone from becoming dihydrotestosterone, and it helps with the excretion of excess testosterone. So it's a really good one. There are some prescription analogs, which I'll talk about here in a second, that, if we need something a little bit quicker and maybe a little stronger, but keep in mind with maybe a few more side effects associated, then we have prescription analogs that we can use as well. But these all are very gentle and also very effective over time. One that I will use for anovulatory cycling, or for cycles that are too short or too long, I will use Vitex or Chase Tree. This is a great one to use. But yeah, again, you'll want to use under the direction of somebody that knows what they're doing, because you don't want to use it for too long, and Vitex doesn't work for everyone. So just, to know if it's going to work for you or not. And then I also like exercise and muscle building. That is huge, right?
Yes.
Yay. So, yeah, I mean, gosh, if you want to resensitize your body to insulin, and you want to regulate your blood sugar, then you need to increase your protein and you need to exercise. And if you want to make your body more metabolically active, you need to build muscle. Right? I mean, muscle is the metabolically active tissue, right? You don't want a lot of fat hanging around because it just kind of sits there. It's pretty inert. But muscle at least burns calories just existing. Okay. Also, stress reduction, obviously. Cut out processed foods and sugar. Stop grazing. Eat specific set meals. Do not graze throughout the day. Stop eating the standard American diet. Like, if it's coming out of a package, it is probably not good for you.
Yep.
Eat as many things as you can without labels.
Yeah. Yes.
Um,
Protein, protein, protein.
yes. Yes. Yeah, absolutely. So let's see. Eat a predominance of your calories during the first half of the day, not the second half of the day. I really struggle with this. I eat way too late at night and it's terrible. I stay up way too late at night and it's terrible. Um, but yeah, so I'm not preaching at you. I'm preaching to myself too here. But also prebiotic fiber, fruits and veggies. Like I said, 25 to 35 grams per day of fiber. Prioritizing sleep, because you cannot metabolize those hormones. You cannot create good hormones without sleep. And try some melatonin if necessary.
Hmm.
But you've got to prioritize sleep.
And definitely, we've already mentioned it before, but definitely hit up our sleep episodes because
Yeah.
we gave a lot of great information and tips on how
Yes,
you
we
can
did.
help your sleep quality.
Yes, we.
So, and Andrea, you've mentioned it before, in the last couple episodes. So
Mhm.
why do doctors revert to birth control for women?
Well, it's kind of like putting a regulator on a cycle, and you can like set it and forget it, right?
Mhm.
So if you want, if you've got a young woman that's coming to you with these horrendous menstrual cycles, and if you want an easy solution, slap her on some birth control pills, and then she will cycle every 28 days according to the pills. Or cycle not at all, just depending on what pill you put her on. But these are synthetic hormones, and they really can cause some problems later on,
Mhm.
which we're finding out. And there are a lot of women, a lot of young women who are very well informed, and they don't want it. They don't want
Mhm.
it. They don't want a synthetic hormone potentially messing with their cycles later on in life, or messing with their fertility later on in life. So yeah, it's a quick fix, but it comes with myriad problems later on. And so
Mhm.
that's why they do it. I get why they do it. This is an incredibly complex issue. And thinking back through the things that we've talked about, can you imagine how long it takes to elicit the information that you need from a patient and in order to treat them adequately? It takes
Mhm.
a really long time. And
Yeah.
often my patients have to come back for 2, sometimes 3 appointments in order for us to be able to get to where they need to be, sometimes more.
Yeah.
And so, often providers just cannot take that time, or they don't know that much about PCOS.
Yeah.
So, I mean, that's certainly a problem too. But that's why if you can just slap somebody on a birth control pill and kind of wash your
Quote
hands a
unquote
bit.
regulate it.
Yeah, absolutely. Yeah.
Mhm.
And then
Yep.
it's done deal.
It's putting a band-aid and not fixing the
Mhm.
problem.
Right.
Yeah.
Yeah.
So what are some other medications that are used?
Okay, yeah. So I mentioned that there are prescription agents that are in my toolkit as well. And so some of the common ones in particular, so I said that, there are some really emotionally laden symptoms surrounding PCOS. So one of the ones that women really struggle with and that are frustrating for certain women, especially if it's significant, is the hirsutism. So this is the unwanted hair growth, right?
Mm.
That's a real problem. And here's what a lot of people don't know is that the hirsutism caused by PCOS sometimes is irreversible.
Mm.
So it's a big deal. It's
Yeah.
a big deal. It's not like, oh, well, get over it. Once we balance your hormones, it'll all go away. No, sometimes it doesn't. And so this is something that needs to be treated. And especially if it's distressing to your patient, then it needs to be distressing to you. And it needs to
Mhm.
be the first order of business. So if it is a particularly significant hirsutic situation, or if she's got like cystic acne that is really causing problems and pain. I mean, cystic acne is horrendous, and it's very, very difficult to deal with. If it's because of elevated testosterone, then I will prescribe something like spironolactone, or aldactone is the brand name. But spironolactone is quite effective. It's a really old school diuretic that we really don't use for much for diuretic purposes anymore, but it also helps, interestingly, to get rid of hyperandrogenization. So it will help to rid the body of testosterone. So if the saw palmetto one, if she's like, well, yeah, I've got some weird hair growth, and well, yeah, maybe I've got some acne, and her labs come back elevated in T, I will try the saw palmetto first. And then if I've got someone who is like, I don't even want to leave the house, I'm so depressed over this symptom or that symptom, then I will weigh the risks and benefits with her of using the spironolactone. Now, an important consideration is pregnancy, because you do not want somebody on spironolactone if they become pregnant. Okay. So again, I cannot stress enough the importance of working with a provider who understands what they're doing, so that you can get people on and off of these medications if you need to use them. Now,
Mm-hmm.
another one, which is extremely common, probably the most common medication used for PCOS, is metformin. And this would be used for the glucose regulation aspect of this syndrome. And so metformin is, well, gosh, this is used in all kinds of circles. It's used off label for weight loss. Now, I've used it in patients who are really struggling with weight. Um, and
And remember, she said berberine is kind of like the natural
yeah,
version.
yeah, exactly, exactly. And berberine doesn't seem to cause the GI upset that metformin does. Metformin causes some serious gas and bloating and diarrhea. So yeah, you want to be careful with using this, because patients can really, really experience some significant side effects from it. But if you start low and go up slowly to the max dose, then the body seems to tolerate it a little better. I also will sometimes use a like a bioidentical progesterone. Like for instance, if I what circumstance? If I need to balance out the estrogen mm, faster than waiting on some of the other botanicals to kick in, then I might use some progesterone to kind of balance out that excess estrogen. If someone is struggling with infertility and miscarriage, and they're having multiple miscarriages, those are just heartbreaking situations, then yes, we use progesterone to maintain pregnancies. And so, yeah, I will cycle some progesterone in those instances as well with PCOS patients.
Okay. So obviously, if we're stressing working with a provider, making sure that
Mhm.
you're holding hands literally with somebody
Right.
walking you through this process with you. So,
Mhm.
what would be a typical expectation for a patient, but with PCOS, from initial visit to follow-up visits? How many do can you
Mm.
give a ballpark average? And what should these appointments typically include? So, when we were talking about our primer on healthcare
Mhm.
episodes, we really stressed about being um, providing upfront before you even step into the office things that you want to discuss with your provider,
Mhm.
because one, that just helps them prepare better,
Yeah.
but it
Yeah.
also helps you know, hey, this is what we're actually going to go, and instead of being
Mhm.
like a blind,
Right.
blindfold and be like, okay, what are we going to talk about today? And
Right. Right.
or even bringing up a question and then blindsiding the provider and being like, well, I didn't prep for that, so I don't have time to answer that. So
Right.
that was a
Yeah.
whole lot of talking. But basically, what should patients expect in terms of maybe amounts of visits that are probably typical
Mhm.
for somebody with PCOS? And then what should these appointments include?
Yeah, no, I think that's all really, really great information. Yes, please do not blindside your provider. Give the front desk as much information as you can, about what you are there for, because gosh, we don't know everything. We do prep for your visits. I mean, we really do. There are probably some that don't, but honestly, like, most people are in primary care to take care of people. Like, we take that really seriously. It's a heavy obligation, and we prepare outside of the office for your visits. So let us know why you're there. And I would say that it depends on the level of stability. So if you are struggling with PCOS and you do not have a diagnosis yet, then you can count on maybe a few more visits up front. And so you might need to come back after that initial visit. Some lab work might be ordered, and then you may follow up on that lab work. And you may receive a diagnosis at that point. And then you may need to come back in an additional 6 to 8 weeks. I'm hoping that your blood work will be timed to your cycle. So that kind of adds some weeks to the equation as well. But then to check in, I don't think it's unreasonable to expect to check in maybe every 90 to 120 days as you're going through a treatment regimen to see where you're at. Now, if fertility is in the mix, then you may need, every 6 to 8 weeks, or even more often, depending on your cycle and where you are in your fertility journey. So if you're actively trying to conceive, then, you could be looking at more appointments than that. But just for a kind of standard, I have PCOS, I'm not stabilized on any medications or supplements, what could I expect? Then yeah, I would say every 90 to 120 days or so to check back in, maybe get labs up to 3 to, oh gosh, if someone is stable, I'd say 2 to 3 times a year just to get hormone labs to make sure you're going in the right direction. Even up to 4 times a year, like once a quarter, to make sure, again, that you're doing what you have set out to do, making sure that those hormone levels are either coming up or down depending on what the needs are. But yeah.
So basic line is find a provider, a good one.
Yes.
Which is
Yes.
always challenging for some folks. And remember, go back to our primer and healthcare
Mm-hmm.
episodes, because we gave some really, or Andrea just broke down beautifully, things that you can do to help search for a provider that will be an advocate for your health. So,
Yeah,
um,
absolutely.
but with that, I think this was very helpful and super informative, and I hope you guys found it the same. I know I learned something, and if you have questions, or if you are maybe dealing with PCOS and you're like, hey, what about this? Definitely shoot us an email or find us on the Instagrams. We would
Yeah.
love to hear from you. And our show notes is our contact information. So scroll down and find our email and our Instagram handles. But as always, we really appreciate you guys listening. And the biggest compliment that we can ever receive is you sharing our podcast with your friends and family. So
Mm-hmm.
just hit that share button. And whether you want to text it or even share it on the Instagrams, that would be awesome. And definitely give us a little mention, and we would love to shout you out for that. And yeah, thanks for listening. And we will catch you on the next episode.
Bye. The content provided in the AA podcast is intended for informational and educational purposes only. The podcast is not a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with any questions you may have regarding a medical condition. The information and opinions expressed in this podcast are solely those of the individuals involved and do not constitute medical advice.